Hello friends, this is Dr. Magendran, your forensic medicine toxicology faculty. I'm back with another video on forensic phosphorus 3.2. This video is on the topic toxicology. In this video, we'll be discussing the explanations of the quiz questions, and we will also be touching upon all the high yield areas which you must know when you're appearing for your NEET PG examination next week. We'll make it very concise so that you can finish it faster. And if you have not attended the quiz, I've given you the link below. You can attend the quiz and come back to the explanations. It will be easier for you to understand the concepts. So let's start with the first question. A patient is in glass-blowing occupation brought with complaints of psychiatric disturbances and tremors. The physician suspected to be mercurial poisoning. Which of the following is true? So to remember, friends, we can see there are few keywords given in this question. Glass-blowing occupation. And which poisoning is common with glass-blowing occupation? That is mercurial poisoning. Mercurial poisoning was also common in hat industries, people working with hat industries. And a person who is suffering from mercurial poisoning will be having psychiatric disturbances and tremors. Okay. So let's see the options, which is true and which is false. Highest concentration is found in the kidney. Okay, mercurial lentis is deposited in the lens. That is true, because mercurial lentis, they can ask you which part of the lens is getting deposited. You need to know that it is in the anterior lens capsule. This is where it is getting deposited, and it doesn't affect the vision. The person will be having a normal vision. Tremor starts in the fingers. Yes, it starts in the fingers, and it starts in the fingers. It progresses into the lip, tongue, and then it moves on to the other parts of the body, like the limbs. Fine tremors seen among the hatters and glassblowers. Yes, tremors are seen in the hatters and glassblowers, but it is not fine tremor, it is coarse tremor. Right? Coarse tremor, it is not fine tremor. And this statement is false. L-penicillamine is used as a chelating agent. Yes, we do penicillamine, but penicillamine we don't use L-penicillamine. The L-penicillamine is more toxic. It can cause optic neuritis. It has got more toxic feature. We use D-penicillamine. Penicillamine, you know, that's a basic degradation product of the penicillin, and it is important for you to have this penicillin allergy history before starting with penicillamine. And penicillamine, we also use it in copper, which is very important chelating agent for copper. This D-penicillamine. Not only for copper, we can also use it in lead. We can as well use it in mercury. Right? So in all these metals, we can use this D-penicillamine as chelating agent. So if you see, this option is also wrong. The remaining options are fine. Moving on to the next question. A 12-year-old boy had an alleged history of snake bite and presented to the hospital with inability to open the eyelids. First keyword. Difficulty in breathing. He is having breathlessness, and he is very anxious and is having tachycardia and tachypnea as well. Okay. And on examination, bite mark cannot be visualized, and there is no swelling of the limb. You remember, bite mark is not visualized and there is no local symptoms. He has bilateral ptosis, and his 20 minutes whole blood clotting test is of good quality. What is the next course of action? Before moving on to the option, first we need to just narrow down which species of snake could have. See, you can see that the patient is having neurotoxic features, ptosis is there, and the patient is having normal 20 minutes whole blood clotting test, so it is unlikely to be a viper. So it has to be a elapid snake. And in elapid snake bite, there are two important possibilities. One is cobra, another one is crate. Right? Cobra and crate. Right? And you can see in the question, I have mentioned that the bite mark cannot be visualized and there is no local swelling. Right? In which of these species there is no local swelling or very minimal local swelling? Yes, friends, it is crate. It is crate. Right? Only in crate the local symptoms will be so minimal, and sometimes often you will not be able to see the bite mark. So we can narrow it down to crate. Now tell me, what is the treatment for crate bite? If it is crate bite, obviously we have to give anti-snake venom, and you don't have to give neostigmine. Let us look up at the options now. Do not give anti-snake venom, but observe the patient. That is wrong, because the patient has already got signs of envenomation, so we have to give anti-snake venom. Give anti-snake venom, keep the patient in observation. Give anti-snake venom, give neostigmine, observe the patient. Reassure the patient, send him home with anxiolytic. This is obviously wrong. So now we are left with two options. One, give anti-snake venom alone. Another one is give anti-snake venom along with neostigmine. Do remember, friends, we have already done this in NEET in many of our lectures. Neostigmine will be more effective only with cobra bite, not with crate bites. Right? It is more effective only with cobra, not with crate. So you have to choose option B as a correct answer, because here we have to give anti-snake venom because it is crate, and you should keep the patient in observation. Okay, so these are the different things we have to do for this particular patient. Give anti-snake venom and keep the patient in observation. And when you're talking about neostigmine, do remember, friends, neostigmine is only used for, it's only effective for cobra bite. It is not that effective for crate bite because the action is very different. In cobra, the action of venom is purely postsynaptic, whereas in crate, the venom acts on the presynaptic area. So the neostigmine will not have any effect on the crate bite. Okay, so the answer would be B. A factory worker presented with tremors, personality change, and blue lines in the gum, probable diagnosis in chronic poisoning with. Before saying the options, first let us localize, let us narrow it down to which metal it could have been. Tremors, yes, tremors and personality change, and blue lines in the gum. Listen, friends, most of the people have been thinking of lead because you see blue line in the gums. But what I can tell you now is blue line is seen with lead alone, right? It is not that it is seen. A factory worker presented with tremors, personality change, and a blue line in the gum. Probable diagnosis in this chronic poisoning with. And before going on to the options, let us see. Let us narrow down the diagnosis. Which metal could it have been? A factory worker presented with tremors and personality change and blue lines in the gum. Most of the people have been thinking of lead as soon as they saw blue line in the gums. Do remember, friends, blue line is seen in the lead. Not only lead, it can also be seen in copper, it can also be seen in mercury, it can also be seen in few other metals like iron, other places, right? In lead, we see the line that is Bertonian line, but it is not specific for, the blue line is not specific for lead alone. It can also be seen in some other metals like copper, mercury, etc. But having seen the other options, other keywords like tremors and personality change, right? This triad of tremors, personality change, and blue line in the gum indicate that the metal is nothing but mercury. Okay, we have already seen that in mercury we can see coarse tremors and psychiatric manifestation. The psychiatric manifestation in mercury, it is called as erethism. It is called as erethism, and I've told you that in the tremors which we see in mercurial poisoning, it's called as Hatter shakes, also called as glass blower shakes. Right? They're all coarse tremors starting in the fingers. Okay, fine. Moving on to the next question. A man working as a pest killer, working in pest killer occupation, coming to the OPD with pain in the abdomen, garlic odor, and transverse lines on the nail. Which of the following combination suggests that the poisoning could have been arsenic? Okay, I've given you the diagnosis itself, that is arsenic, but I want you to know which of this combination is more diagnostic towards arsenic poisoning. Whether it is pain abdomen, garlic odor, transverse lines on the nail. Okay, see, the garlic odor is specific for thallium. It can be seen with arsenic. It can also be seen with phosphorus. These are the three poisoning wherein we can see this garlic smell very commonly. And transverse lines on the nail, we call it as Aldrich-Mees line. Aldrich-Mees lines. We can see transverse white lines on the nails. Okay, these are the two important things. One is garlic odor and transverse lines on the nails. They are suggesting that the poison could have been arsenic. These are the two important findings which indicate that it should have been arsenic. Okay, fine. A bus passenger who was offered sweets by a co-passenger presented with dilated pupils, facial flushing after being duped. Which of the following is not seen in such poisoning? Right? As soon as we see a passenger is being duped with sweets or something like that, and the person is presenting with dilated pupils, The only one thing which we can think of is datura, because datura is the common railway poison and a roadside poison which is often used to stupefy people. Roadside poison. It's mainly to facilitate robbery. Okay, it's used to facilitate robbery. We can see the dilator. You will see all the anticholinergic toxidrome. Anticholinergic toxidrome. And you should also know that in datura, what is the active principle? It was a last year question. Hyoscine and atropine. These are the two important active principles of datura. Okay, and when we are talking about datura, hyoscine and atropine, we need to think of anticholinergic toxidrome. Anticholinergic toxidrome, the person presents with dilated pupils, dysarthria, dysphagia, dry skin, drunken gait, delirium, and death. So all 8 Ds would be there. Thinking about all the 8 Ds, we can now look at the options: urinary retention, high temperature, delirium, drooling. Okay, it's very it's very logical to think that normally anticholinergic toxidrome is the one where we can see normally decreased secretions, not increased secretions. It is decreased secretions, everything would be dry. So obviously the drooling will not be present in such patient. You can see urinary retention. Yes, you can see the urinary retention. High temperature will be found, and delirium will also be there, and drooling will not be present because there will be dry mouth, not drooling. And the delirium which we see in datura is called muttering delirium. It is called muttering delirium. Okay, fine. The Indian polyvalent antisnake venom consists of the venom of, right? The Indian and polyvalent antisnake venom, because the antisnake venom, it varies from country to country. It is normally customized based on the species present in that country. So whatever species of snake which are present in our country, our anti-snake venom will be customized towards those snakes. Right here, I've given you the scientific names. I've not given you the common names. I've given you the scientific names. So you should be knowing the scientific names as well. Okay, this is level 2 difficulty, but still you should be knowing what are the scientific names of the common snakes which we see. Naja is nothing but common cobra. Hypernail, okay, it is your hump nose viper. Echis carinate, it is saw-scaled viper. Tabio Russell, it is your Russell's viper. Bungarus ceruleus, it is our common crate. And Ophiophagus, that is our king cobra. Okay, so these are the snakes, common snakes. Now we can easily find out the Indian polyvalent anti-snake venom will be effective in whatever the snakes. See, Indian polyvalent anti-snake venom is normally effective in 4 snakes. That is your common cobra, crate, Russell's viper, and saw-scale viper. These are the 4 snakes against which the Indian anti-snake venom will be effective. So the Indian anti-snake venom will be neutralizing the venom of these 4 snakes. And you should also remember that the Indian anti-snake venom is not effective in king cobra. Okay, we can use only neostigmine as the symptomatic measures. The king cobra will not respond. The king cobra venom will not respond to our Indian polyvalent anti-snake venom. Just remember 4 snakes: common cobra, crate, Russell's viper, saw-scale viper. Right? Moving further. A patient is brought with suicidal consumption of sulfuric acid. Which of the following is not seen with sulfuric acid? Chalky white tongue is noted. You must have learned chalky white, the term chalky white in sulfuric acid. But do remember, friends, it is not chalky white tongue, it is chalky white teeth. Right? Because the sulfuric acid has got hygroscopic property. It will absorb all the water content. It will make the surface so dry, hygroscopic nature. That is why we can see chalky white teeth, not tongue. Okay, so this option is wrong. Carbonization of stomach mucosa, yes, we see blackish stomach mucosa. We can see perforation of the stomach. We can see perforation because sulfuric acid is the most powerful acid. We can as well see the blotting paper stomach, which is so fragile and thin. right? So the option for this would be option A, where the chalky white tongue is not noted, chalky white teeth is noted. You can see the snake. This is our king cobra. Which of the following is false regarding this particular snake bite management? I've already told you in king cobra snake bite, we are anti-snake venom. We can't give our Indian anti-snake venom, that is not effective. Okay. Now let us see what are the options given here. Tourniquet to occlude small veins and stop the venom spread. Remember, should not be any usage of tourniquet. This is basically false. We should never use tourniquet. We can use bandage. We have seen earlier. Reassure the patient. Yes, we have to reassure the patient. Should not give any coffee or alcohol. Carry the patient. You should not allow the patient to walk, because preferably you should carry the patient, because it will reduce the spread of the venom in the body. And no anti-snake venom is necessary. That is also true, because I told you that it is not working against king cobra venom. So the correct answer for this question would be A. That is a false statement. A person is accused of causing hurt to another person by giving drink laced with poison, which is punishable under dash section. Okay, so this is causing hurt to another person by giving drink laced with poison. Okay, he is giving a drink and he is intentionally causing hurt with this poison. He is punishable with dash IPC. It is 324 IPC. Causing hurt by dangerous means. 324 IPC is the one which gives punishment for causing hurt with or by dangerous means. Poison is also one of the dangerous means. If the person is causing hurt by giving a poison, we can say that it is punishable with 324 IPC. If a poison is given to stupefy a patient and for the facilitating robbery, we can say that is 328 IPC. And 302 IPC is for murder. So we cannot, if the patient has not died, so we cannot say the 302 IPC applies here. You are working in a casualty as duty medical officer. A patient is brought with history of homicidal kerosene consumption because of false statement regarding the management of this particular patient. Kerosene poisoning patient has come, right, which is false. It is mandated to inform the police before starting any treatment. Do remember, friends, it is, you should inform the patient, you can inform the patient, but not before starting the treatment itself. Not before starting the treatment. Always the medical duty, it carries more priority than the legal duty. First you have to treat the patient, save the patient, then you can start doing all your medical duties. So this option, first option itself is wrong. Gastric lavage is not indicated. You know very well, kerosene poisoning, it is volatile, it can evaporate. You should not give gastric lavage. Activated charcoal again is not effective in this kind of you're working in a casualty as DMO. Your person is brought for the history of homicidal kerosene consumption. And pick out the false statement regarding the management of this particular person. It is mandated to inform the police before starting any treatment. Gastric lavage is not indicated in the treatment. Activated charcoal will not be effective. Failure to preserve the evidences is punishable under 201 IPC. It is a homicidal poisoning, so we have to inform the police, but not before the starting of treatment. It should be after treating the patient. Always the medical duty, it is more important than legal duty, right? For treating the patient, saving the patient is first utmost priority. Then we can start working on the legal duties, documentation or intimation to the police, all these things. Gastric lavage is not indicated. Yes, kerosene is a volatile substance. You should not do gastric lavage because it can cause chemical pneumonitis by causing aspiration. Okay. Activated charcoal will not be effective. Yes, it is not effective. Activated charcoal does not absorb kerosene, so it is not that useful. Failure to preserve the evidence is always punishable under 201 IPC. Yes, that is true. We have to preserve all the evidences in any case of homicidal poisoning. If we are not doing it, it is punishable under 201 IPC. The answer for this would be option A. That is a false statement. 5-year-old male brought to the casualty by his mother because of the episode of sudden vomiting. He has been behaving strangely according to his mother, also complaining of weakness of the hands and feet. On examination, we can see the pale lethargic child, discoloration of the gums noted, wasting of the muscles of the hands and feet, microcytic hypochromic anemia with basoflex stippling. Which of the following false? Which of the following is false regarding this condition? But what is this condition? This condition is nothing but your plumbism. This is nothing but chronic lead poisoning. Okay, we can see the basophilic stippling. We can see the discoloration of the gum, that is Burtonian line. We can see the wasting of the muscles of hands and feet. This is a case of plumbism. Lead encephalopathy commonly seen in children. That is true. Burtonian line is noted. Yes, that is also true. We can see the Burtonian line in chronic lead poisoning. Lead palsy is noted among the extensors and it is an early phenomenon. That is wrong. It's false. Because normally speaking, the lead palsy is noted among the extensor, but it is a late phenomenon. It's not an early phenomenon. Okay, wrist drop and foot drop is a late phenomenon that's not normally seen with early stage itself. Saturnine colic is nocturnal, that is true. The person will have nocturnal colics, that is also true. So option C can be chosen on this question. Next question, a patient is brought with suicidal consumption of oxalic acid, which is suitable for oxalic acid poisoning. Systemic symptoms are not severe as it is acid. No, oxalic acid is an organic acid. Any organic acid will be having local effects. We can as well see the systemic effects as well. If they ask you what are the examples of organic acid, we can think of phenol, we can think of oxalic acid, we can think of formic acid, boric acid, hydrofluoric acid. We have many examples on it. Okay, carbolic acid, oxalic acid, formic acid. It causes hypokalemia. It causes hypokalemia. Hypocalcemia is commonly noted. Perforation of the stomach is not that commonly noted. Parathyroid extract, sometimes it is indicated because of hypocalcemia. In oxalic acid, we can see hypocalcemia. The patient presents with features of tetany. So we have to manage the patient. Okay, with this, we have to manage first the hypocalcemia. Okay, we can either give IV calcium gluconate, and sometimes it is parathyroid extract as well. This is very important part of your plant irritants. We have to know the plants and their active principles as well, the toxic principles as well. So many times we come across questions on this. So let us see. Castor acid. What is castor acid? Castor acid is nothing but, castor seed is nothing but Ricinus communis. Castor seed. Ricinus communis, and you know very well, castor seed, when it is crushed, it is toxic. What are the active principles of Ricinus communis? We have ricinoleic acid and we have ricin. Both are the active principles. So this is true. Marking nut. What is marking nut? Marking nut is nothing but your Semicarpus anacardium. Semicarpus anacardium. Bilava. So the active principles would be bilavenol. Active principles would be bilavenol. It is semicarpal. These are the two primary active principles of marking nut. Madar. Madar plant is nothing but your Calotropis. Calotropis. We have 5 important toxic principles in Calotropis. Calotoxin, calotropin, gigantin, usharin, and calactin. We have 5 important active principles of Calotropis. So both these pairs will be right. Spanish fly, cantharides, cantharidin, that is true. Gunchi seeds. Gunchi seeds is nothing but your rati seeds or Abrus precatorius. The active principle of Abrus precatorius is abrine, abralic acid. We have many active principles, but gigantin is not active principle of Abrus precatorius. That is basically wrong. A dead body is brought with suspected poisoning, is having hypostasis of brown in color. What should be the, what about the statements 1 and 2? Statement 1, it is suggestive of poison due to cyanide. That is basically wrong, because in cyanide we don't get brown color, we normally get brick red or bright red. Okay, and brown we normally get it in potassium chlorate, nitrate, and brown color hypostasis due to meth hemoglobin. That is true. Right? Statement 1 is false. Statement 2 will be true. 39-year-old carpenter has taken 2 bottles of liquor from a local shop. After about an hour, he develops confusion, mental confusion, vomiting, blurring of vision. He has been brought to the emergency department. What should he be given? Okay, so the normal illicit liquor, the common illicit liquor which a person consumes is methanol. So this is a case of methanol poisoning. We can see the vomiting, the blurring vision as well. The person will also present with abdominal cramps. What is antidote for methanol poisoning? It's a very straightforward question. It's so easy. Methanol poisoning, 4-methyl pyrrosol can be used. You have fomepizole. Apart from the fomepizole, we can as well use ethanol. Right? We can also use fulinic acid. The person will be having metabolic acidosis. So to treat the metabolic acidosis, we can as well give IV sodium bicarbonate. Okay, so the answer would be option D. A 28-year-old male admitted with history of accidental consumption of 1 seed from this particular fruit. First of all, identify the toxin. The poison is nothing but your Strychnos nux vomica. Strychnos nux vomica, which is a spinal poison, one of the toxic spinal poison, very fatal. This is regarding this case, which is not correct. Convulsions affect all the muscles at a time. That is true. When a person is suffering from nux vomica poisoning, convulsions occur all at a time. All the muscles will go for convulsions. The dose is too less for toxicity. What is the dose? Consumption of 1 seed. Right? In this case, even 1 seed. In nux vomica poisoning, even 1 seed, 1 crushed seed can also be fatal. Okay, this is wrong. If you look at the fatal dose of strychnine, the fatal dose of strychnine is 30 milligrams. Pure strychnine, active principle is 30 milligram, but 1 crushed seed itself is fatal. Brain is preserved. Do we preserve the brain? Yes, we can preserve the brain along with spinal cord, because this is a spinal poison, so we can preserve brain and spinal cord. That is true. Postmortem caloricity is seen. Yes, what is postmortem caloricity? Postmortem caloricity is nothing but, right, the body remains warm after death within 1 or 2 hours. Normally we see a decrease in body temperature after death, that is called alga mortis, but in this case there is a small rise in the BB, or the body temperature remains warm after death. It's called postmortem caloricity, which is typically seen in nux vomica poisoning also. Okay, prostatonas is seen. Not only prostatonas, you can see opisthotonus, you can see emprostatonas, and you can see prostatonas as well. All the 3 tonus can be seen because of the contractions of the spinal muscles. So which is wrong here? Option B is incorrect. A farmer ingested unknown poisonous seeds and had pain and vomiting. Soon he developed paralysis of the lower limb, which essence till it affected the respiratory muscles. He died within 2 days. The poisoning is due to. It is starting in the paralysis starts in the lower limbs and it ascends upwards. Ascending paralysis. The only poison which you can think of commonly is conium maculatum, hemlock. Conium maculatum. Right, this is the poison which causes ascending paralysis. And this is the one which has got carrot smell. Hemlock. 40-year-old male abuses alcohol voluntarily for 15 years. He could not get alcohol for 4 days due to the closure of liquor shops in view of election. He was confused, could not sleep properly. Right? Acute withdrawal, alcoholic withdrawal syndrome. He also assaulted his neighbor. Right? What is his condition? It is delirium tremens. Under delirium tremens, the patient will be having hallucinations and delusions can be noted. But in this confused state, he assaulted his neighbor. He is fully responsible. His family is responsible. Is partially responsible, and he is not at all responsible. If a person commits a crime under this delirium tremens, will he be responsible or not? The person is not responsible for the crime, because under delirium tremens, the person is in acute insanity. The person is in acute confusional state. The person won't be able to know whether what he is doing is right or wrong. That's why he is not responsible at all. Ramesh presented with bronchodilation, increased temperature, constipation, tachycardia. Dilatation of bronchus, increased temperature, constipation, and tachycardia. What is the probable diagnosis in poisoning way? Is it morphine, atropine, arsenic, OPC? It is atropine, right? Because we can see that bronchodilation, increased temperature, constipation, tachycardia. Okay, had it been morphine, we will not be getting increased temperature. There will be hypothermia, and there will be bronchospasm as well, right? In arsenic, we don't see such features. OPC poisoning, yes, in OPC poisoning, we get bronchospasm, and again we get increased bowel sounds in OPC poisoning. The bowel motility will be increased, GIT motility, and we'll also see bronchospasm. There will be intense sweating, myotic pupils. All this is seen with OPC poisoning, and which we can easily remember it as dumbbells. Diarrhea, urination, meiosis, bronchodilation, bronchospasm, bradycardia, emesis, lacrimation, and salivation. So these are the features which can be seen with OPC poisoning, and the treatment for that would be your atropine. Not only atropine, we should also give oximes. Okay. A teenager was abusing this specific drug. Features of overdose and poisoning are all except. So this is nothing but cocaine, which is obtained from erythroxylum cocalis. Cocaine, crack. Basically, what we have to learn is cocaine is sympathomimetic. It will increase the sympathomimetic activity. Sympathomimetic. Now, if we look at the options, we'll be able to easily find out which is wrong. Okay, features of all overdose and poisoning are all except we need to find out which is not seen with cocaine poisoning. Myocardial infarction, yes, very much possible. Epileptic seizures, very much possible, because initially it causes CNS stimulation, the person gets excited, and when excitation increases in case of poisoning, the person gets convulsions. Hypertension, yes, because cocaine is a potent vasoconstrictor. It's a potent vasoconstrictor. That is why in chronic cocaine poisoning, we see peripheral gangrene as well as one among the features. So this is also noted. Increased release of norepinephrine in the synaptic cleft, that is wrong. It is basically not due to the increased release of norepinephrine. It is the cocaine acts by inhibiting the norepinephrine noradrenaline reuptake in the synaptic cleft. That is actual mechanism of action for cocaine. So this is the image which was shown. The very commonly abused substance, that is your cannabis, which is incorrect statement regarding the cannabis. Ganja. Ganja is prepared from flowering tops. Yes, flowering tops of female plant, not male plant. This is false statement. Flashback phenomenon is seen. Yes, flashback phenomenon is seen not only in LSD, we can also see that in cannabis. Sinsemilla is a seedless preparation. Yes, that is true. That's a true statement, correct statement. Sinsemilla is a seedless preparation. There is no specific antidote. Yes, that is also true. You don't have to need any specific antidote, because the fatality is very, very less, rarely reported in this cannabis, because the amount of fatal dose itself is too high. Run amok is not seen, that is wrong. Run amok is seen in Ashish insanity. It is seen with cannabis, chronic cannabis abuse. Right, so this statement would also be false. Okay. "35-year-old man admitted with history of suicidal consumption of poisonous plant." This is the poisonous plant image. Relatives are able to identify the photograph. This is nothing but yellow oleander or Pila Kaner. yellow oleander. The scientific name is Cerbera thewacea. That is a scientific name of yellow oleander. Which of the following is false? Which is not correct? Active principle is carabin. No, that's wrong. Active principle is perovskite. That is true. Not only perovskite, we can see thevetin, thevitoxin, cerberin. These are the various active principles from yellow oleander. It causes hyperkalemia, that is true. It also causes hypokalemia. Hyperkalemia, both are possible with this yellow oleander toxicity. Continuous ECG monitoring is needed. Yes, of course, because the person is prone for cardiac arrhythmias. We need to have a continuous ECG monitoring for the management of this patient. So all the options were right except this option A, that is wrong. About this poison, what is this poison? The most rapid poison, the ideal suicidal poison, that is your cyanide. Amyl nitrate should be given as first choice IV. Amyl nitrate should be given, right? If you remember the lectures which we are discussing about cyanide, the treatment, you might be remembering that amyl nitrate is given initially, but not IV. It is given inhalationally, right? It is given inhalation. So this statement is false. Patients with chlorhydria have good diagnosis, good prognosis? No, not at all. Patients with achlorhydria will have good prognosis. Okay, so this statement will also be false. Smell of bitter lemon noted? No, not at all. Smell of bitter almond noted? So this statement is also false. Antidote is hydroxycobalamin. Yes, this is the most preferred drug of choice, because here in hydroxycobalamin there is no risk of methemoglobinemia. Sometimes what happens when you give nitrate, it induces methemoglobinemia, which is useful for the excretion of cyanide. But not only that, if the methemoglobinemia concentration is exceeding, sometimes it itself can become toxic. It's a double-edged sword. So this hydroxycobalamin does not have the risk of methemoglobinemia. That's why this is preferred than nitrates. A patient was found in a locked room having labored breathing, kerosene-like smell, pinpoint pupil, yes, frothing from the mouth, cyanose, pulse rate is so less, 40 per minute, Brady. Which of the following is correct regarding to the management of this patient? First of all, we need to find out which poison the person must have consumed. It is nothing but OPC, insecticide, organophosphorus compounds, OP poison. That is the reason why the patient is having all cholinergic toxidrome. You can see pinpoint pupil, increased salivation. Okay, you can as well see the bradycardia. We've already discussed about dumbbells. I've told you what are the different features you can see in this OPC poisoning. Now regarding the management, which is false. See, atropine sulfate IM should be given till full atropinization. Atropine sulfate should be given, that is no other doubt, but it is preferred, IV route is preferred, not IM. This statement is false. Oxime should be started after aging of the enzyme. Do remember, oxime should always be given as early as possible. As early as possible, because you need to give it before the aging of enzyme. When the enzyme has gone for aging, the oxime will not be having good effect on it. So it has to be given before the aging of enzyme, not after aging. So this statement will also be wrong. Chromodactyluria may be seen. Yes, it is. You can see the red tears in this OPC poisoning. So this is a correct statement. P2AM given IV 1 to 2 milligram along with atropine. We do give P2AM, that is oxime we gave, but it is not 1 to 2 milligram, it is 1 to 2 grams IV. Okay, so we need to learn, we need to read each and every word in the option. Okay, so there might be so many distractors among the options. We need to read each and every word to pick that up. Okay, so for this question, option C would be the better option. A victim recovered from a burning closed hut brought to the hospital. The patient looks like intoxicated state. Which poisoning it is? It is carbon monoxide poisoning, very important to note. And person who is suffering from carbon monoxide intoxication might have intoxicated like state. The person might look as if it drunk, but it is not basically drunkenness. It is carbon monoxide intoxication. Let us see which is true regarding the management. The first aid is to give oxygen at a low flow continuously. It's not low flow, it is high flow. We need to give high flow oxygen continuously. Metabolic acidosis, yes, because the patient will have what is called as anemic anoxia. The patient will have anemic anoxia, which can result in metabolic acidosis, right? Symptoms of poisoning starts when the concentration is less than 10%. Logically speaking, it should not be less than 10%. It should be more than 10%. It should not be less than 10%. So that option is also false, right? Gastric lavage to be done immediately. But here there is no reason for gastric lavage because it's an inhalant poison. There is no need for gastric lavage. This is also false. So among the given options, the correct option is option B. Metabolic acidosis may be seen in this particular case. A man coming to the emergency department with history of substance toxicity, excess salivation, pinpoint pupil, kerosene smell on breath. I put so many MCQs on OPC poisoning because that is one of the most commonly encountered poisoning in the emergency department. So we have to know each and everything about this management of Organophosphorus common OP poisoning, which is false regarding this management. Atropine is specific antidote. Charcoal has got no additional therapeutic benefit. Atropine does not reverse the muscular paralysis, there is weakness. Oximes to be started after 24 hours for the maximum therapeutic benefit. Just few MCQs back, I was telling you that oximes have to be started before the aging of the enzyme, not after aging of the enzyme. So I have already told you that oximes has to be started. Oximes have to be started as soon as possible, not after 24 hours. So this option would logically be wrong. It will be incorrect. Everything else is right. Charcoal has got no additional therapeutic benefit because charcoal does not absorb with OPC. Insecticide, charcoals are not indicated. Atropine does not reverse the muscular paralysis weakness. That is true. Nicotinic actions cannot be reversed with atropine. Okay, so these are the high yield points about toxicology which we are must to know, which are must know for your NEET PG preparation. So do subscribe the channel. So, do get updated with the other videos on the remaining topics, thanatology and identification. Good luck.